Okay. Yeah, this is a registry we started in 2021 when I was a fellow at the Aga Khan University Hospital. Left bundle area pacing is a promising alternative to conventional cardiac resynchronization therapy. Now, the African population is a bit different from the population in the developed countries. Like my colleague, Dr. Josephine, mentioned, we see a lot of patients with very wide, very dilated chambers. And these patients, they tend to have very wide QRS complexes. And the data on left bundle area pacing outcomes in an African setting is scarce. So the objective, also one of the secondary objectives of our registry is to evaluate the procedural and clinical outcomes of left bundle area pacing among African patients with very wide QRS durations. So I'm presenting a subset of the data from our registry. So it is called multi-center African cardiac conduction system pacing, multi-center African cardiac outcomes in pacing, MACOP. So it haven't caught up yet. So we enrolled 311 patients between 2021 and 2024. And these are patients who had various indications for left bundle area pacing. About a quarter of our patients had bradycardia, so that was the indication. 56% had heart failure, so this was for resynchronization, and then 16% had atrial fibrillation, so slash AV nodal ablation. Most patients were from South Africa at Dr. Brian Vezi's center, and Nairobi at the Aga Khan Hospital. So we evaluated procedural and clinical outcomes. So as part of our secondary objectives, we wanted to look at the results when we stratify patients between normal QRS, wide QRS, so between 120 and 159 milliseconds, and then very wide QRS, 160 milliseconds and above. And then we also subdivided patients in LBBB and non-LBBB subgroups. The mean age was 65 years, 46% were female. The median follow-up at this point is 6 months, because some of them were discharged from the registry, and the mean pacing threshold at implant was 0.6, and at follow-up it had not really changed, so it was still at 0.64 with a non-significant, a non-statistically significant difference. The mean QRS duration at baseline, so before the implant, was 136 milliseconds, while at follow-up it reduced to 118, and it was statistically significant. The mean fluoroscopy time, which is a surrogate on how difficult the procedures were, was 9 minutes. Now, when we subdivide our patients in very wide versus normal QRS, surprisingly, patients with very wide QRS were younger. And when you look at fluoroscopy time, patients with very wide QRS had higher fluoroscopy time, suggesting that these patients, the procedures in these patients were technically more difficult. Now, when you look at patients with heart failure, defined as a left ventricular ejection fraction of less than 50%, most of these patients had very wide QRS. So, among patients with very wide QRS, 90% had a low EF, and among those with wide QRS, around 70% had heart failure, and then those with normal QRS, only about 30% had heart failure. Now, when you look at post-implant QRS duration, even among patients with very wide QRS, at the beginning, before the procedure, after the procedure, it came down to about 120 milliseconds, which was similar to those with the wide QRS. And then those with normal QRS, actually it went up a little bit as expected. So as conclusion, patients in African cohort undergoing left bundle area pacing with very wide QRS seem to be younger. So these are short-term insights, I must say. And they had longer fluoroscopy time, and they had a lower LVEF, and have higher post-implant QRS duration. So MARCOP registry is starting to give us, starting to highlight specific consideration for left bundle area pacing in patients with very wide QRS in an African context. Thank you.
Question. So seemingly all the patients with very wide QRS are having positive findings. So did you do echocardiographic analysis of what really happens in between the very wide and the normal? Because I'm assuming actually the very wide are the ones who have already quite dilated heart, and definitely a dilated heart with poor anatomical morphology, you're definitely going to take a long fluoroscopic time. And then in your follow-up, how long did you follow up the patients? Did you do LV strain to look at improvement in the LV function also?
Well, we did not do LV strain. We only looked at LVEF. And so that's part of the primary objective. We are going to publish the data hopefully soon. So I don't want to give it away. So I want you to read the paper. So this is just for the secondary objective, and we looked at LVEF. No, we didn't look at longitudinal strain or other metrics. As for follow-up, it's 6 months. So we are actually still recruiting patients. Yeah, some of them have been in the registry for long. Some of them are lost to follow-up, and some of them are new. Yeah.
Willie, can I just ask, at your follow-up, did you guys specifically check for conduction system capture at follow-up, or because you presented threshold testing, so I just want to know were there patients that had successful implants but that follow-up had deep septal pacing? Because from my experience, that can happen not infrequently.
Oh, we did not look at that. Yeah, we just looked at the capture thresholds. Yes, please.
Thank you, really, for the perfect presentation. Any data about extraction?
So far, we've had a a few lead repositioning, but no extraction.
Does anyone have experience on left bundle area lead extraction?
Not chronic leads, but acute leads, sometimes they can be quite difficult to, once they're embedded in the septum, my initial experience was that it was quite difficult sometimes to extract, and in some cases I've actually had to leave the lead in. Yeah, I don't have experience with long-term left bundle extraction.
I have extracted some of them. The key is do not cut the lead. Don't cut the lead, just go with the sheath over it, and then use that as your straw. If you cut the lead, it will spiral out of control. It will just unravel in your hand. So when normally when you want to do extraction, there's no lumen, right? So you have to just leave the lead intact and use at least a 12 French. I use laser, but even if you're going to use a cook, use something a little bit oversized, so that the connector pin can go over it, and you leave the lead intact as you do the extraction. I always encourage people to use a bipolar cautery so that you don't damage the insulation. If you use unipolar cautery, you may damage the insulation. And so you want to leave the lead intact as much as possible, and then don't cut it and just go over it and intact like that. So, and it's not been difficult. And when you get to the tip, I just manually rotate, and it comes out very easily, yeah.
And Felix, don't you think?
Sorry, I'm not. Oh, sorry, yeah.
A comment on your answer. Don't you think this is a missing piece in the long-term follow-up for the wide adoption of this pacing technique for lead extraction for infections or things like this?
Yeah, because, the leads are quite reliable, and oftentimes when you have to extract them, it's either, infection or threshold creep. I know when we were doing a lot of fixed bundle pacing, it was a little bit frustrating. By the perforation doing an extraction in the each bundle position, because I think the lead was in the membranous portion, and I think that's why the threshold crept up. Luckily, we're able to manage with pericardiocentesis and just stop the bleed. But you have to be careful. You want to be, for the left bundle area, it's not an issue. I think it's actually a little bit more comforting to extract in that position. But I think we should probably track all the experience with that and let people just, maybe have the technique written out here.
There is another session. Go ahead. Thank you, Willie. The next session is a recorded abstracts and cases, and we run them in a row. But now we have to announce the results of the elections. Felix, please come here.